Thank you, sir. It's really an honor and pleasure to be a part of this program. So I thank you, Harsh sir, for such a nice introduction. I'll be speaking about when it is not glaucoma. Am I audible, sir?
Yeah, you are fine.
Thank you, sir. So we all know about glaucoma, that a majority of the glaucoma in our country is still not diagnosed. But also what we also know that 50% of the patient whom we are treating as glaucoma probably don't even have glaucoma. So like underdiagnosis is a serious problem. Over treatment also has a very important problem, and it has got a very important impact on the society as a whole, because we know glaucoma has become like a stigma with increasing awareness about the disease. I'll share you how it all started. This patient I was seen almost 12 years back in early part of my training at Shankar Nethralaya. This was the patient who came to us. He's a 38-year-old gentleman already undergoing treatment for juvenile open angle glaucoma for almost a year. The pressures was 12 millimeter mercury on brimonidine. Patient was already undergoing treatment. When we went to the records, the patient had a pressure of 22 millimeter mercury recorded with a non-contact tonometer maybe 4 or 5 years back. Angles were open on gonioscopy. CCT was on the higher side. And if you see the field, very advanced field loss in both the eyes. So basically based on the cupping and advanced field loss and the pressure of 22, the patient was put on medication. This is the OCT of the patient. You can see there is thinning of RNFL in both the eyes. But if you see the disc is very important. If you see the right eye disc is around 0.7 with some superior thinning. The left eye definitely has got advanced cupping. But the correlation of the disc and field is extremely important in glaucoma. You see the correlation of the right eye with the field. When you see a glaucoma patient with a 0.7 or a 0.8 cupping, we don't expect this type of advanced field loss. Plus the presence of pallor is something which goes beyond glaucoma. So whenever you have this type of mismatch between your clinical finding and your investigation report, you should think beyond glaucoma. And in this patient, when we took a detailed history, patient actually had a history of methyl alcohol poisoning. So a lot of these methyl alcohol poisoning will come to you after 2 years, 3 years, 5 years. They will come with cupping, which is sometimes very difficult to differentiate from a typical glaucomatous cupping. In these cases, a proper history, proper evaluation of the patient and correlation of your finding with the investigation is very important. Also, one point we need to highlight, a lot of time patient will send you a WhatsApp report or will of a OCT or a perimetry and ask your comment about glaucoma. It's very difficult to comment unless you've seen the patient in totality. And just looking at the perimetry or OCT can be misleading, because investigation, for example, like OCT will tell you whether you have RNFL thinning or not. Whether the RNFL thinning is because of glaucoma or for a traumatic optic neuropathy or because of an old retinal vein occlusion or a methyl alcohol poisoning, this is something which you have to determine based on your clinical finding. So we cannot blindly rely on any of the investigation. So whenever you have these young patients with non-metastatic glaucoma, because we know non-metastatic glaucoma is a disease of elderly population. Young patient with non-metastatic glaucoma, too much of pallor or defects obeying vertical meridian, early involvement of central vision, you should think beyond glaucoma. The reason also I shared this case because we know of late we are getting a lot of cases of methanol poisoning because of too much use of sanitizers. So we may get some cases like this in future which may mimic as glaucoma. Another very important thing is, especially for the young practitioners who have started practicing for glaucoma or in ophthalmology, glaucoma diagnosis is a life-changing diagnosis for the patient. And I like to share the story of this girl, Neha. The picture is just representative, which I've seen almost 10 years back. And she was around 24, 25-year-old. When she came to the OPD, she looked more like 35 or 36-year-old. She was depressed, taking antidepressants. And when I went to the record, patient was actually having a physiological cupping. On evaluation, we found it was a physiological cupping, but she was put on anti-glaucoma medication because sometime the NCT showed a pressure of 22, 23. Patient had large cup, and OCT showed some area of RNFL thinning, but the fields were normal. So in a busy OPD, when you make a diagnosis of glaucoma and you move to another patient, the diagnosis of glaucoma can have a very important impact on the life of the patient. For this particular lady, the marriage got cancelled because she was diagnosed as glaucoma, and the groom's family was not willing to marry a glaucoma patient because of the risk of hereditary factors. So this diagnosis is a very important impact. So whenever you are confused, you're not sure about diagnosis, don't use the term glaucoma. You can write, say, this suspect or raised IOP or ocular hypertension. And you can always reevaluate the patient after a week, 1 month. We don't need to jump into a diagnosis of glaucoma. I'll share one more case. Mr. Vadva, who came to us in 2012, already a known case of normal tension glaucoma. He was hypertensive. The left eye was lost due to fungal endophthalmitis post cataract surgery. Right eye had a 618 vision with a significant cataract. Patient was already on one medication, which was beta blocker. Angles were open, pachymetry was fine. There was inferior thinning with a superior field defect. So we found that the patient was well controlled on one medication. You can see a mild inferior thinning here. Since the patient was well controlled on one medication, we thought we just go ahead with cataract surgery. The surgery was uneventful. Patient got a good vision and was then lost to follow-up. He came after almost 7 or 8 months. By that time, again, the vision was 6 normal vision. Patient was on prostaglandin, and there was some mild thinning and mild amount of pallor, which was not very significant. But the patient was very insistent that he's not able to see. And we thought he's just probably maybe just patient is maybe a little over demanding patient because the vision is normal. But since the patient was so insistent, we did the OCT macula was normal. We also did the perimetry, and we were surprised to see the perimetry report that there was a marked progression in just a matter of 7 months. From little bit of superior defect, there was a dense superior defect, and which was encroaching the fixation also. So whenever you have these patients with a marked progression on well-controlled intraocular pressure, there's certain investigation we should do. One is an office diurnal or a 24-hour diurnal if you have the logistics or the infrastructure to do it. In this case, the pressures were normal. We should also have a carotid evaluation, a cardiac evaluation to make sure we are not having any systemic factors which might be affecting the ocular blood flow and be causing this progression. Also, we should be doing a 24-hour blood pressure assessment and a sleep apnea evaluation. In this patient, if you see the fields again, this patient had a visual field where the fields were sort of respecting the vertical meridian and looked more like a quadrantanopic defect. Because in glaucoma, you have more of a field defect into the arcuate area and not such an early involvement of the fixation point. This definitely gives an indication that probably it is something more than glaucoma. And when we did a neuroimaging, patient actually had a suprasellar mass. This was a case of a granuloma, which was compressing the optic nerve and optic chiasma. The patient was referred to neurologist and was later found to have a fungal granuloma. This probably had no relationship with the previous fungal endophthalmitis, but the patient had a history of fungal endophthalmitis a few years back. So again, these type of patients who are established case of glaucoma, you know they are having glaucoma, but suddenly you see any progression, even with well-controlled pressure, these cases definitely you should look into other aspects, as I've already mentioned, plus also recheck your gonoscopy, look into the compliance issue, and have a neuroimaging whenever you have a doubt. The next case I'd like to share is Mr. Jha, who again came for consultation in 2014. The pressures were normal. This patient was already on prostaglandin analog. The vision was normal. CCT was 530. The gonoscopy had open angles. And if you see the field in 2014, the baseline pressures were also normal. The right eye was perfectly normal. Left eye, there was some superior defect, which looked, if you just see it, the field looks more like a low tension glaucoma or a normal tension glaucoma with early involvement of the fixation. And that is why the patient was already on treatment. This is the disc in the right eye, around 0.4, 0.5, looks to be pretty healthy. Left eye definitely has some inferior thinning. This is the data evaluation. So you can see definitely the left eye inferiorly is looking thin. But if you see in more detail, the left eye, which looked like a thinning, there is a grayish depression in this area. Also very important, whenever you're seeing this unilateral glaucoma, unilateral normal tension glaucomas, we should always think of secondary causes plus, because normal tension glaucoma is basically a diagnosis of exclusion. So you need to look into other aspects also. This was actually a case of an optic disc pit. CCT was not diagnostic, but there was some area of localized depression. But sometimes OCT can be useful in patient with optic disc pit because of associated subretinal fluid. Sometimes you can see a membrane over the optic disc and cystic spaces inside the optic disc. So this was a case of optic disc pit. So whenever you have a patient like this, you should first stop anti-glaucoma medication. recheck the pressure after the washout period, which in this case is 4 to 6 weeks. We did an office diurnal after 4 to 6 weeks, and the pressures were all found to be normal. But very important, you should clearly mention in the file that patient needs to be under regular follow-up, because I had a patient with ocular hypertension where we stopped the medicine, the pressures were normal. 6 months down the line, the patient was again having normal pressure, but the patient was lost to follow-up and came back after 3 years with a frank glaucoma. So always keep these patients under follow-up, maybe 6 monthly or 1 yearly, but do mention that you should be under follow-up, because you never know, patient may have some other pathology or may have a raised intraocular because of some other reason in future. So whenever you're stopping medication, the responsibility is probably even more than starting anti-glaucoma medication. This patient had a follow-up of 5 to 6 years. You can see all the fields were stable because basically it was an optic disc pit, so there was no progression in this case. The last case I like to share, this is a patient, Mrs. Das, who again came for consultation, already established as a case of glaucoma for 4 years, already on prostaglandin, and the baseline pressure was 18 millimeter mercury. Patient came for a second opinion. Visions were normal. The pressure was normal. CCT was also 520. Angles were open on gonioscopy. You see the disc again in the right eye, maybe around 0.6 to 0.7. The superior rim slightly thin, but the disc is following the ISNT rule, and the RNFL also looking pretty okay. The left eye also is around 0.6 to 0.7, but a fairly healthy neuroretinal limb. So very important is seeing the disc first before you see the OCT or the HVF, so that you create an image about the disc before you see the investigation. So when I looked at the disc, I find this looks to be pretty okay. Even the red-free photograph, there is no RNFL thinning as such. But if you see the perimetry, definitely there was some nasal defect and superior defect. So just looking purely on the perimetry, you will be carried away that probably it's a case of glaucoma. This patient, when we did a dilate, and this patient was not having any learning curve because this field defects were persistent for almost 4 to 5 years. When we did a dilated evaluation, we found that there was a retinal scar, and this was just classically matching with this perimetry report. So if you have not done a detailed evaluation, you have not found the reason why these field defects are there, this patient will be treated for glaucoma for rest of his life. There's cost involved, there are the side effects involved. And when we dilated the patient and saw that this was the reason why the patient had this persistent field defect. Even the OCT also was done and it was normal and matching with our disc finding. So dilated evaluation is extremely important. Even with the most experienced glaucoma experts I've seen, undilated, you're bound to miss those early changes. You're bound to miss these retinal scars and disc hemorrhage. So always have a dilated evaluation. In case the patient is having angular glaucoma, you can do a PI and then dilate and do a detailed evaluation of the disc. So to conclude, I'll say every patient of a glaucoma deserves a comprehensive evaluation. Field and disc correlation is extremely important. Don't rush to diagnose a glaucoma, normal test of glaucoma 1 week, 2 week, 1 month. Nothing is going to happen. Take your time. If you're confused, reevaluate the patient after a week, 1 month. Whenever you have established patient with unexplained progression, do investigate to try to find any cause. And regarding neuroimaging, every patient with atypical presentation or atypical progression, do consider neuroimaging. Definitely the cost is involved, but even if you diagnose one patient with a tumor or a granuloma or some other pathology, is going to change the life of the patient. So whenever you have a doubt, do consider neuroimaging. Thank you so much.
Thank you, Manish. I think that was really beautifully